Started back. Sorry we're packing so much into such a short period of time, but this is a topic that's, I think, interesting and engaging. So I'd like to introduce you to Dr. Lori Peek. She's the director of the Natural Hazards Center at the University of Colorado. And I've been working with her pretty closely for the last couple of years. It's been very rewarding. And she, like me, is a serious advocate of collaboration and is going to spend some time talking about even more collaborative ideas. So.
Hi, everyone. Thanks for coming in from lunch. I work a lot with economists as well, and so I have incentives up here. There's going to be a pop quiz. There will be gifts, because it is lunchtime. And at first, I wanted to just say I am so excited to be here, and I am so honored. Last night, I was talking to my mom and my dad. I grew up in this tiny town in Kansas, and I said, "Mom, I'm going to get to give this talk today," and she said, "Make sure and tell them people in Kansas are really nice." I said, "Okay, Mom." But I just, so in that spirit, I want to really say thanks to Tom and Norma and Alice and Kendra and the entire group at USU for putting this event on. And thanks to all of you for being in here. I am deeply honored to be with you. As Tom said, my name is Lori Peek, and I am the director of the Natural Hazards Center at the University of Colorado Boulder. And for over 40 years, the Natural Hazards Center has served as the National Science Foundation designated information clearinghouse for hazards and disaster information. And so with the support of the NSF and the U.S. Geological Survey, the CDC, Health and Human Services, what the center does is that really four things. And so the center is dedicated to translating and sharing information. And so all of what we heard this morning about taking research and trying to make research count, that's one of the things that we do at the center. We have these up here for you. A second thing that we try to do is to facilitate connections and collaborations between natural hazards researchers, practitioners, and policymakers. A third thing that we try to do is advance new social science and interdisciplinary knowledge. And a fourth thing that we do is train and mentor a diverse next generation of hazards and disaster researchers. So to begin today, I'd like to ask if all of you in your post-lunch moment, if you would pause for a minute and if you would think about a moment when you have come together with others, and in particular, a moment when you have come together with others with the specific intent of solving a problem. And that may be in your personal lives. It may be in your professional lives, but a moment when you have actually come together with others to solve a real problem. Everybody have that in their head? So coming together is something that we've been thinking a lot about at the Natural Hazards Center, and especially coming together in ways to solve problems. And when you stop and think about it for a minute, we spend our entire lives in connection with others. Before we are even born, we are literally physically connected to another human being. And then throughout our entire lives, we are deeply interconnected in both seen and unseen ways with other people. One of the things in this hazards and disaster community is that we often come together in order to assess the many challenges that we face. And the hazards and disaster community has been doing this for over 70 years. But one of the things that we're moving towards is really thinking about how do we assess problems, but then also how do we come together in order to think about ways to develop solutions to those problems. The National Academies of Science and the National Science Foundation have really been spearheading in this century a movement toward convergent science, where this is a working definition I use, which is about teams working together in novel ways, crossing borders and boundaries, whether they be disciplinary, political, or ideological, to solve some of the most vexing social, environmental, and technical challenges that we are facing. One of the things we heard this morning from Craig Fugate was about how disasters serve as a forcing function. That disasters oftentimes force us to come together to solve problems. But we also heard this morning that oftentimes the institutions in which we work are actually antithetical to those sorts of forcing functions. And so teams in the context of disaster can work together really well to take a specific problem. But when problems get bigger and more complex and require interdisciplinary collaborations, oftentimes our institutions actually work against the processes and the structures that we need to do this kind of convergent science. And so what I'm going to talk about today are two initiatives during this time, during the lunch hour, and I'm going to just share a brief overview of two initiatives that are really about trying to do this, about trying to bring people together to solve vexing problems. The first I'm going to talk about is a new National Science Foundation Converge initiative that we are spearheading at the Natural Hazard Center. The second is a much larger national alliance for a North American alliance of disaster research institutes. And so first, I'm going to begin with Converge. And one thing I want to acknowledge that is interesting about talking about convergence and collaborative science is that I, as an individual, am standing in front of you to talk about two projects that are deeply, deeply collaborative. And so at this moment, my name isn't on the screen, and I hope you will know that I'm trying to speak on behalf of and alongside many people who are working on this effort. So 70 years, that's how long disaster researchers have been working systematically in this field. And I would actually like to take the position that we are safer. We are much safer today in 2019, and that countless lives have been saved because of that disaster research. And how can I say that with certainty? I'll give you some specific examples. That today, modern building codes and standards are a direct outgrowth of quick response disaster research. Improved warnings and alerts, evacuation protocols, coordination of spontaneous volunteers, recognition of the highly vulnerable populations, these things are a direct outgrowth of 70 years of disaster research. But I stand before you today, along with the other disaster scientists in this room who have been raising this question, what is the next 70 years going to look like? Because we are on a collision course with catastrophe. In an era of climate change, unsustainable development, population growth, and rabid social and economic inequality, these two record-breaking disaster loss years that we are coming off of, they are not a new normal. They are a harbinger of what is to come. And so one of the things that many of the disaster scientists in this room, as you've already been hearing today, have been arguing is that these rising threats, it is going to cause us to need to take a fundamental different approach to hazards research and disaster science. And so this question about the next 70 years. How is it that our natural hazards research and disaster science community, how are we going to respond to these rising threats that we face? This is one of my forever questions that I carry around with me everywhere. And it is a forever question that is at the heart of this new Converge initiative that we are taking on with the hazards and disaster community. And so I'm going to share with you briefly 6 of the major tasks that we are working on through the Converge initiative. And with this is going to come with some invitations to join us in this effort. And so one of the first things that we are doing is we are working to establish a new social science, and as I'm going to say in a minute, we are using a very broad definition of social science to establish and support a new social science extreme events research network, as well as a new interdisciplinary science and engineering extreme events network. In August of 2018, we issued a call to social scientists to join SSEER. And in the months since then, we have had 683 social scientists globally who have signed up for the Social Science Extreme Events Network. And if you go to the Converge map, that's up at converge.colorado.edu, right now we have geolocated those social scientists around the world, and you could see the majority of them are in the United States, that we have geolocated them. You can find name, organization, affiliation. But thanks to the social scientists who filled out this 7-minute form, we also have additional data layers that we are getting ready to add to this SSEER map. And so shortly, you're going to be able to go to that SSEER map, and you're going to be able to search for the researchers who do public health and medicine and who have studied particular disaster events. And you will find that on the SSEER map. I want to pause and acknowledge that there are several individuals in this room who actually agreed to serve on the SSEER Advisory Committee and joined together in February at the University of Colorado Boulder to help launch this network. And so I want to thank those individuals who said yes to this. And I hope you will see their university affiliations are up there, but these individuals represent a range of social and behavioral sciences, but also public health and medicine, as well as the humanities, because right now, under this social science umbrella is the big umbrella under which we are working. Eventually, we might have a public health or medicine EER, but for now, we're working under this umbrella. Now, I also want to say that the SSEER and the ISEER are part of a much broader National Science Foundation ecosystem of building up extreme events research networks to try to bring together members of different disciplinary communities to do this work, but also to bring them to do cross-disciplinary, transdisciplinary, interdisciplinary, and multidisciplinary work. And so GEAR, the geotechnical group, has been around for over 20 years. The social science, structural, nearshore, and interdisciplinary groups have all been established within the last 3 years. So this brings us to the second thing that Converge is working to do, which is trying to work to advance scientific agenda setting as well as coordination among these National Science Foundation-supported extreme events research networks and the facilities that support the work that they do. A third thing that we are doing through the Converge initiative is to develop a series of free training modules as well as short briefing sheets for the hazards and disaster research community. And this is really in recognition that as the number of disasters have grown, so have the number of disaster researchers and hazards researchers. With each fresh event, oftentimes what we're seeing are new researchers coming into the community, and oftentimes they are not always aware of the long legacy and long history of research that has been done in this space. And so are people going to be experts after they do these training modules or read a briefing sheet? No, but will they hopefully have some sense of that long history of the research in this community to help move it forward? Okay. A fourth thing that Converge is doing is working to fund and support both virtual reconnaissance. In the era that we are living in, there is so much data and so much information that is rapidly available. We're stopping to ask a question about for decades, people go into the field with field reconnaissance, but with the increasing onslaught of data that is widely available, when can we do virtual reconnaissance from our desks to learn about what's going on in the hazards and disaster field, and when do we actually need to see teams move into the field to understand what is happening? And this is building on the Natural Hazard Center's long-standing quick response research program, but also bringing in new partnerships. Dee Dee Bennett is here, who runs the NSF Includes Minority Surge Capacity and Disasters Project, as well as the Bill Anderson Fund, which is now housed at the University of Delaware, to ensure that these next generation researchers are reflective of the diversity of the communities that are oftentimes struck low by disaster. A fifth thing that we are doing through the Converge facility is actually partnering with the NERI Rapid facility, which is at the University of Washington, to accelerate the development of mobile applications for hazards and disaster research. And there are several people from the University of Washington in here. How many of you have an iPad or an iPhone that's available to you? And so this is one of the things that the NERI Rapid facility is developing, is a mobile application to help systematize the collection of data in the aftermath of disaster, building on other excellent reconnaissance work that has done this. And then the sixth thing that we are doing is also partnering. The National Science Foundation has funded the cyber infrastructure for the nation in order to curate, publish, and freely share data in a secure environment. And so this past week, one of the things we're doing with Converge, the engineers have this long culture of data publication, data sharing, and we're working with DesignSafe to ensure that the data models that are available already are working for the engineering community. They have over 100 data sets that have been published over the past 3-4 years on DesignSafe. But we're working with them to develop a social and behavioral science as well as an interdisciplinary data model to ensure that we have an opportunity to publish our data. So this past week, I was like, okay, if we're helping build this, I got to publish a data set on here. So I put this little data set up on DesignSafe. It's literally little. It's like 8 columns. And I got so excited. I was like, I've published my first data set. And you know, team, I was not excited because I have another line on my Vita, because this is what they do. They actually assign a DOI to your data set, and we're working with them because we recognize with social and behavioral scientists what we heard this morning. Actually, what we oftentimes need published from social and behavioral scientists are our data collection protocols. What we oftentimes need are our surveys and our interview instruments published, so then we're not recreating homemade scales and measures with each new disaster. So anyway, so I put my data set up there. I got so excited because I thought, you know what? Somebody may go get that data set and they're going to go do something with it that I never could have imagined, but they're going to do something more creative, better with it, and that's what DesignSafe is about that free, shared access, data use, data reuse. Okay, there's going to be a pop quiz in a minute. Okay, how am I doing? Okay, good. All right, we're on time. I'm going to be done by 1:30, I promise, Tom Kirsch. Okay, so please join us. This summer at the 44th Annual Natural Hazards Workshop, we are going to continue this conversation around convergence. And we are going to be featuring a series of projects as well as leading scientists, practitioners, and policymakers in our field who are going to be talking about the thorny issues that they are attempting to solve through convergent activities. So I hope you will join us. Now, okay, everybody, get ready. There's going to be a pop quiz and prizes, and there are several people from the University of Delaware in this room, one of the disaster research centers. One of the questions in the pop quiz will involve the DRC, so they are not allowed to answer the question, because that would be called cheating. Okay, so now, what I'm going to talk about is a second collaborative initiative with a second invitation to join us. So this second initiative that I'm going to talk to you about is this North American Alliance of Hazards and Disaster Research Institutes. And again, I am very self-conscious that I am standing in front of you as an individual when this is actually the complete representation of a collective work of dozens and dozens of individuals over more than 2 decades. So I really want to say that at the outset. And I also want to say that what I'm presenting today was specifically developed by the organizing subcommittee members who you can see their names up there, including our esteemed leader, Tom Kirsch, Carl Kim at the University of Hawaii, Paul Kovacs at Western University, Charlie Scawthorne at the University of California, Berkeley, and Rich Olson at Florida International University. Okay, so first question. The first academic disaster research institute globally was founded in 1951 at what university? Oh, he can't answer. Tom has seen these slides. Kim Schoaf.
The Ohio State
Oh, I am sorry. That is not correct. David Abramson, I saw. Okay. Yes. I'm sorry. That is not. Scott Miles. That is not correct. I'm sorry. My friends, you must think broader and more globally. It is outside of the United States. Japan. Okay, Tom Kirsch gets a water bottle. So DPRI at Kyoto University was founded in 1951 in Japan. Now, for all you Delaware fans in the room, I knew I couldn't have a question because you'd all get that one right. So this is a different question. The Disaster Research Center, which is the first in the USA, was founded in what year? Oh, who said 63? Oh, my friend. Okay, here you go. Congratulations. Okay, third pop quiz. 63 at the Ohio State University, now at the University of Delaware. Third pop quiz. How many hazards and disaster research centers are there in the USA, Canada, Mexico, and the Caribbean? 17. So in 1963, there was one. In 2019, there are more than 17. Less than 300. I've covered up 125. Who said that? Oh, well, you give it one of the because that was close. So as of today in 2019, and thanks to the efforts of the hazards and disaster community who have responded to us, we have identified 169. As you can see, the vast majority of them are in the USA. We've identified 353 globally, and we're not sure that's a complete census at all. That's just what we've been able to identify, but we have this map up on the Hazard Center website. And this is important because one of the things that the North American Alliance of Hazards and Disaster Research Institutes is about trying to change the landscape. But one of the things we recognize is that you can't change the landscape if you don't understand the lay of the landscape. So one of the first tasks that we had was try to identify how many hazards and disaster research institutes are there. So last question, you don't have to answer this one. This is my job. So what is this North American Alliance all about? So a very brief, very, very brief history to bring this into focus. So for decades, the leaders of various hazards and disaster research centers and institutes have opportunistically gathered in the summer at this annual Natural Hazards Workshop that is conveniently held in a very beautiful location in Colorado. And for many years, they had talked about we need some kind of collective group, a collective voice, some kind of alliance or coalition to raise up our voices as center directors. In 2015, this global alliance was formed in Japan after a UN meeting to try to bring together disaster research institutes globally. In 2017, our group of center directors voted with the leadership of Tom Kirsch and said we do want to form some kind of group or alliance. And then we formed an ad hoc volunteer steering committee to try to bring that into action. And so in February of 2018, a group of center directors and institute directors gathered for 2 full days in Boulder, Colorado to try to sketch out. We said, we've been talking about this for decades. What is it going to take to move this into action? So we met. These are the members of the volunteer steering committee who met together to try to figure this out. And one of the biggest outgrowths of that February meeting is that we needed to write a charter. We needed some kind of guiding documentation to move this group forward. And so that is what we did. We wrote a draft, short 11-page, short for academics, 11-page charter. I know you heard that. A short 11-page charter. We presented it to we sent it out in June of 2018. And then in 2018, in July, a group of 52 center directors ultimately voted to ratify the charter with modifications that were discussed at the meeting. And so this is the group at the meeting on July 8, 2018, who voted to move forward with forming this alliance. And so right now we are an organization in formation. And the invitation that comes with this conversation is on tomorrow afternoon from 1 to 4:30. We're gonna have a meeting to follow Tom's meeting to talk about moving this alliance forward. And so the vision at the heart of this is to try to figure out how the different leaders of centers and institutes, as well as their partner organizations from federal agencies, the private sector, the nonprofit sector, the philanthropic sector, can work together to achieve outcomes that would not be possible without that kind of collective voice. So this is words on a screen. I want to give you a really concrete example of why it is that we feel like we would like to have this North American Alliance. How long did the government shutdown last that just happened in 2018-19? 35 days. 35 days the government shutdown went on. And hazards and disaster scientists, the leaders of these centers, were individually speaking up and saying this has to end. There is data that's not being collected that will never be made up. We'll never get that back. A disaster, a catastrophic event could happen tomorrow, and our best leaders from our federal agencies, they're not at work. This has to end. But those were individual voices in our hazards and disaster community who are saying that. We're trying to figure out if we had a collective voice where we could make statements like that, what might that mean? It's dead. I don't know. I've wondered this. Got to. Okay. Help. Okay. I'm almost done. I have 2 minutes. I'll wing it. Okay. I can. It's okay. I only have 2 minutes left. I can finish it without it. Okay. Whoever helps gets a water bottle. Okay, so 2 minutes. So what our mission is, we are trying to figure out how to advance the research enterprise, how to do a more effective job in terms of working toward evidence-informed policy and to encourage advocacy among this broader group in ways that we are able to, and also to work on the translation, transfer, mentoring, and training of the next generation. And so our geographic scope for this North American Alliance is, again, right now, the USA, Canada, Mexico, the Caribbean, as well as tribal and indigenous areas. And last summer, this group of center directors articulated a desire to perhaps have the entire Americas, the entire region engaged in this, but because we did not have representation from Central and South America, we are waiting until we can have a collective voice from those areas of the world. So there are 3 membership categories. There are Category A members, which are the directors of hazards and disaster centers. Associate membership is also open to non-affiliated hazards and disaster scientists who might want to be a part of this group. And then Category C affiliates of people from agencies, organizations, private and public enterprises who are interested in joining. And so this organizing subcommittee has been working, and we call ourselves the Great Disappearing Subcommittee because we are going to go away at the end of June. We have just been doing this because part of what the charter requires is that there has to be a board of directors in place, but we realized we had a gap in our work, which is that we didn't have a process to get the board of directors in place. And so the 6 people you see up there, we said we will serve as this disappearing organizing subcommittee to figure out a process for how we can get members in place so we can elect a board of directors. So our goal, and that's what our meeting is about tomorrow, we're going to talk about the process of how we're going to get membership for this group and how we're going to encourage membership, but then also how we're going to encourage people to run for this board of directors to help stand up this North American Alliance. Right now, the temporary secretariat is at the Natural Hazard Center, but the board will determine where that will be located, and we will turn that over, and then committees will be established. And so here's the invitation that tomorrow from 1 to 4:30 p.m., Tom has generously set aside a room for us to talk about standing up this alliance and exactly what we need to do to continue to move it forward, so that we will then be ready in May to release our call for applications, which we have a draft of that already that we'll talk about tomorrow. And then so in June, all of the directors of these 160 plus centers in North America will receive an invitation to vote for the board of directors. And then all with the goal that on July 14th at the 44th Annual Natural Hazards Workshop, that the first official meeting of this North American Alliance will be stood up by this newly elected board of directors so that we can move forward with a stronger collective voice. And so with that, thank you so much for taking the time during your lunch break to listen. Thank you for the work that you do, and we wish you very well and look forward to collaborating with you. Thank you very much.
Our next panel, please. Thank you, Lori. That was great. As you can see, there's a lot of stuff going on, which is exciting from many different areas. And I think this new movement to collaboration speaks well to the future of disaster science, per se. So now we're going to turn to the perceptions of the responders.
Lori has another gift.
Yes, thank you. I didn't even answer a question. That's great. Because one of the unique things about this meeting, in fact, is getting responders involved. One of the troubles that academicians and feds both, in their own way, tend to do is stay rather insular. And so reaching out to the response community and understanding better their needs and their perceptions of disaster science is an important part of this. So let me introduce Mr. Ed Gabriel. I actually met Ed during the 9/11 response. He didn't remember me because I was a minion and he wasn't. Ed organized and ran the 9/11 response in New York City after that event. And I used to go sit in on the briefings and listen. I was working with the Red Cross at the time. So he's going to run this panel and can introduce the rest of the guests. Thank you, Ed. You guys have to sit away from me? Is that- Yeah.
What a great opportunity, and let me just say to start off with, I come from the response community as a field guy for many, many years, and it's interesting. I can tell you it's great to hear, my friend here talk about how I ran the 9/11 response. I mean, the reality in New York City, it was 300 personnel in our operations center, a combination of federal, state, and locals, volunteers, and it was an event that, if you were like me, completely engaged in it. I was certainly a leader there as the Deputy Commissioner of Emergency Management, but agencies talking to each other make success. It's never an individual, it's always a group of individuals working together, which is what's so exciting about having an opportunity to stand here as a response guy and have this conversation with all of you. And I'm listening to the presentation prior to this, and I can tell you that it's an interesting perspective. When you go to a scene of an incident, which I've done a lot of times in my career, and you stand in front of that incident, no one there is thinking study. Nobody there is thinking analysis. What we're thinking is, how do I save the lives? Where are my resources best deployed to? How to protect my people? What other things am I missing in terms of the response? But there is a real place for study. There is a real place for study. But most of you are not part of that team. When it comes to those kinds of responses, there's got to be a trust built between the people that are doing the study and the people that are doing the work. And that connection point sounds great as you begin to move forward in the kinds of work that you're going to hear from our three panelists here. There's nothing more important than that. And I have had the opportunity over the years where somebody said to me, well, we'd like to study how you respond to a major building collapse. not a World Trade Center collapse, but a major building collapse. How do you study that? You want to get in on it as quickly as you can. You want to watch what's going on. You want to do the things you normally do in terms of study. But if you can't get past that chief that's running that incident, and he or she doesn't know who you are, you're not going to get that close. They're worried about you. They don't know what your background is. They, quite frankly, may or may not trust you. So then you have to absorb information from a different perspective, right? I'll challenge you all. Get yourselves into those spots. It's dangerous, but if you can get yourself as close as you can to the event when it's occurring, you will see things you had no idea really went on. From everything from patient movement to patient management to decisions around where patients go to, if you're looking at it just from a medical perspective. How do they triage those individuals? What's the standards for that to succeed in real life events? It can go on for hours. The key is you don't see that visit. If you're not there and you're not there quick enough and you're not trusted by the team, you are going to be one of those people where you're just not going to have the visibility to really get a real feel for it. And by the way, while you're building it, and I heard this before earlier, it's great. Think about having response people sitting on those committees that you're going to develop underneath this new national hazards group that you're putting together. Trust me, they'll probably be a lot quieter than me. I'm from Brooklyn, so, But there's a lot of people out there with a lot of experience. You just heard from one this morning, Craig Fugate, who was, again, another guy who came from a local perspective to be the head of FEMA. So today, we're going to have individual little presentations without slides, from our panelists. We're going to turn it over to them, and then we're going to have some open questions and answers. And you're all able to ask any questions you want, and we'll see as a group how we can answer those questions, okay? What I'm going to do is I'm going to actually, what's the next slide? Can you press it for me? I don't think there is anything now. There are no slides. That's right, no slides. You listen to Tom, no slides. So why don't I have come up come on up to introduce yourselves, and then we'll give a short presentation. We're going to try to stay on schedule. Thanks. Sure.
Hi, so I'm Megan McGinty. I'm going to just give you a little background, and the only reason I share this background is just so that you see how it informs the remarks I'm going to make. So I'm also from Brooklyn, so we stack the deck here. I'm a former EMT, a local public health practitioner. I previously served as Director of Continuity of Operations Planning at the New York City Health Department. And most recently, I was Deputy Director of the Big Cities Health Coalition, which is a forum for the largest, for health departments from the largest 30 cities in the US. Now, this distinction between researchers and practitioners, for me, it's artificial. I consider myself both a practitioner and a researcher, but I think there are distinctions for the vast majority of people. So in addition to being a practitioner, for the past 2 years, I've added a column in the journal Health Security where I worked with local health departments trying to get them to publish reports from the field about their experiences. And then I did my own dissertation research on Hurricane Sandy. So I have a little perspective on both sides of the coin. So in thinking through this, we were asked to not provide slides. So I made an outline of things that I wanted to share with all of you. So first, I think that there are some key challenges that we can talk about. One is capacity, one is capability, one is consent, and then the other is communities. So first, in terms of capacity, in general, with local health departments, there is limited capacity to conduct response, let alone research. So just to give you a sense, the average health department in the country has around 57 employees. A health department that serves under 10,000 has around 8, and a health department that serves a population over 1 million has around 780 employees. 2% of health department staff are preparedness staff. So it's very few personnel to conduct response to the disaster, let alone research to the disaster. In addition, many health departments have limited capability to conduct research. So they don't necessarily have staff in the departments that are that have been trained in conducting research. They're not necessarily familiar with research protocols. They don't necessarily have IRBs. I happen to work at a health department that has its own IRB and that would conduct research regularly, but that is not common in the majority of health departments. Okay. And that's true too of nursing homes, long-term care facilities, EMS organizations. They're first and foremost responsible for public health and safety or medical care, not conducting research. So even in departments that may put a priority in conducting research and may buy into and really be on board, they don't necessarily have the capacity or the capability to do that research. So that means partnerships with all of you is essential. So the third challenge is consent, and I hear this a lot from a lot of our departments. There's a big concern when you go out into the field and you're doing response. Is there confusion on the part of the public about whether you're doing research or whether you're doing response? So if I come to your door to do surveys to figure out who's been affected by a particular hurricane, or you show up at a shelter and I'm asking you questions, are people in the public consenting because they want access to the services that you're offering them as part of the response? Or are they consenting of their own free will? Is there a clear distinction to the public that the activities that you're engaging in or the information you're requesting of them is for response or for research? And so that's an issue that needs to be navigated, needs to be worked out with your partners at local health departments and other health institutions. And then the last challenge that I wanted to talk about was just communities. And I say communities because there isn't just one community. So there's the public writ large as a community, but there's also the community of workers in local health departments, there's the communities of EMTs. And so there's a question, not only are you getting the input of the community in which you want to do the research, the disaster affected community, but are you also getting the input of the practitioners with whom you need to partner to do that research? So have you gotten the input from the fire department, the health official, et cetera? So I want to just invoke two adages from emergency management, which when I hear these at emergency management conferences, I roll my eyes and I'm like, oh, can't we move past these? But I think that they're relevant for remembering some of the recommendations that we can use to address these challenges. So the first adage is that you don't wait until a disaster to exchange business cards. And I'm like, oh, yeah, we know partnership. Okay, that's important, right? But the reason I say that is because partnership is really important here for researchers to be partnering with communities and all of the communities that they want to do research with. So if we're going to educate health departments about research protocols, about consent, about IRB, if we're going to get their input on what research questions should be asked, we need to establish those partnerships in advance of the disaster. You need to be known within the community that you operate with so that, as Ed Gabriel mentioned, they trust you, and the health department, the fire department, whomever you want to do research with is willing to let you be on the scene, observing what's going on, actually conducting your research. And then the second adage that I want to invoke is that all disasters are local. And so the reason I mention this is that I think that all disasters, all research that's conducted in disasters need to be informed by the local community that's been affected. So that means that if we want research to be usable, if we want it to be applied, it has to answer the questions that practitioners have. It can't be some question that people up in an ivory tower or the Citadel think is an interesting question. It actually has to be a question that practitioners that are responding to the emergency need answered in order to improve the response. Dean Kellerman mentioned that journal articles should have a key findings box. And Mr. Fugate was talking about urging us to be direct and explicitly say what we should do differently. And I think that those are great recommendations. I would advise any of the graduate students that I teach that they should do that in their scientific writing. It would be great if we were all better writers. But I would challenge us to think even more radically than that. Most local responders don't have access to peer-reviewed literature. They're not reading their literature. Mr. Fugate's an exception to the norm. Okay, and so first, I would say that all disaster research should be published open access. And I think that one way to facilitate this is that it should be a requirement of any federal government award for funding to conduct disaster research, that research be published open access. That's first. And so if you're a disaster researcher, even without that federal mandate, and you are developing your grant proposal, build the open access fees into your grant fee so that you can make it open access so that practitioners can access it. But I would push us to go even further, and I would invoke a pop culture reference. So I mentioned the Citadel. Literature can't be locked up in the Citadel for only Samuel Tarly to access, okay? If you want to affect the strategy that the Night's Watch is implementing in the battle, right, you need to actually reach them. So if you want to impact how they defeat the Nightwalkers, you actually have to reach them in a medium that they will use. So that means that we can't just publish in peer-reviewed literature. You actually have to produce products that are useful for people working in the field.
And as the third member of the Brooklyn Coalition, I bring you guys greetings. Midwood. So I first want to just thank you all for the invitation. I will admit that I am a little uncomfortable speaking to the needs of state and local responders because of where we sit. I think I got the invitation because Tom is just tired of having these conversations with me. So I welcome your indulgence. I first want to explain a little bit about Healthcare Ready and where we sit and throw an acronym that I actually don't think you all have probably heard at you because we don't have enough acronyms in the space. So Healthcare Ready is a nonprofit. We are a public-private coalition, and we were actually established by the healthcare supply chain. Normally, when people think about the healthcare supply chain, when all of you think about the supply chain, you're not actually thinking about the supply chain. You're either thinking about manufacturers or distributors, but that's fine. We were established by truly the entire supply chain, all the way down to hospitals and the Red Cross, all the way up to source manufacturers, because people realized in the private sector that preparedness and response required a full-time effort. However, no one had the time. And it would really, if you think about it, across the number of companies and entities that are represented across the supply chain, the amount of investment that it would take to do this well and coordinated across an entire industry, you probably want to do it in a coalition. And so for us, that was really the reason we were created, and I think the reason that we still exist, because since Katrina, when we were actually created, what we found was that the private sector, counter to what most people typically believe, thought they could do more and they could be better. But they didn't think that they had the relationships and the information that they needed to do that efficiently. So again, they just created us and said, go solve the problem. But as that, the acronym I want to throw at you is ISAC. Are any of you familiar with the term? Dwayne, you don't get to raise your hand. All right, so ISACs are actual DHS, it's a DHS designation for Information Sharing and Analysis Center. The reason that this matters is because there are ISACs across all of the different critical infrastructures. Healthcare Ready is the healthcare ISAC. In healthcare, I should say there are two ISACs. One does cyber, one does non-cyber. So we do everything else. And the reason that this matters is because as we're thinking about data and information sharing, and we're thinking about who has access to what our ISAC designation and our role as a coalition and a public-private partnership does, is it allows us to absorb information from the private sector. We often have answers to the questions that our public sector partners are trying to ask and can't really get answers, but it gives us a mechanism to be able to hold the information, store the information, downgrade some of the information to be able to answer these questions. And so one of the things that we've realized over the last few years is that actually over 13 years of operations gives us a lot of historical data that, if managed differently, might actually be more useful to the field, especially if we could get it in ways that allow for us to be able to share it more broadly. But it also, and I actually was going to make this point last, but I think I'll make it now, it also gives us sensitivity to the nature of the information that we are collecting and holding and sharing. And if we're thinking about how to do disaster science better, that is going to be an issue we have to contend with. This question of how do we manage sensitive information, whether that information is simply because it's critical infrastructure that is housed by the private sector, or if it's because of vulnerabilities that exist and there's a national security lens to it as well. Oftentimes we find that, especially when we're talking about supply chain, but really often distributors, there are questions about capacity that may come up in the healthcare supply chain that can be answered, but cannot be answered in a manner that would allow for us to put the information out publicly. And so if we're thinking about kind of that tension between what needs to be in the public space, what needs to be usable by the field, and how do we manage this issue of sensitive information sharing, because frankly, we can't put ourselves in a situation where we don't have access to that information because we got one good paper out. How do we balance those tensions? Another thing I'll mention, we actually do a lot of supply chain analysis, and again, a lot of that is in mechanisms that are a little tough to share publicly, but we do have something that we designed intentionally to be public, and that's called RxOpen. I know some of you are familiar with the map and have used the map and the data, but what RxOpen does is, because of data sharing agreements that we have in place, we are able to report out to the public, to emergency managers, the status of open and closed pharmacies in a disaster zone. So there are a lot of people who don't even realize that Healthcare Ready operates the RxOpen map, and I'm seeing nods like, oh, you're the person. Yes. So Healthcare Ready's map is something that we intentionally had to really work to make sure it could be public because of the nature of the information. And we do have a lot of colleagues that have figured out ways to pull the data and use it in their analysis. And so when we're thinking about healthcare and the healthcare system recovery, it allows for us to really think about the role of ancillary care, specifically pharmacies, and how it plays out. I do want to make a point, because of where we sit, that we often find that we have to speak two languages. We speak to our public health partners, but we also have to speak emergency management, which is very much its own language. And one of the realities that's been touched on quite a bit is the tension between practitioners, people who will say, I'm on the ground, don't be too academic with me, and the need for their buy-in. And I do think there's a bit of an opportunity now. Some of us that do see the value in being able to build that evidence base have been, I think, really pushing the strategies for how you do things like publish a paper and an op-ed at the same time. And so I think there's willingness, but there's also recognition that those are two different languages, and there is a bit of a reticence to think about how academics play a role. And I just think it's something that we have to figure out how to overcome. From the planning perspective, and I figured I would look at it from the lens of the questions we're typically asked and the types of information that we're asked to provide. And from the planning perspective, I think a lot of what we see in terms of questions pertain to infrastructure. But for states and locals, the question is often, how can we assess what infrastructure exists in the broadest sense of health? So it's not just public health infrastructure. It's what does the healthcare infrastructure look like? Who owns it? What do I need to know about power, water, fuel often? And how can we get that information in a way that is digestible, usable, and can help inform our planning assumptions? And that question is kind of the what, if you will. But I think it quickly flips because it's both a what and a where question. Oftentimes we find that there is a solution that is accessible that becomes the hammer that goes in search of any possible nail that it can find. And so I think as we've been starting to ask these questions about critical infrastructure, we found ourselves in a similar position where we're trying to understand where the critical infrastructure is located, what those dependencies are, and how to get that information in a format that is readily digestible by our partners. And then finally, thinking about this question of real-time data. That's been something that, especially in the emergency management space, has been kind of the make or break. And I'm personally of the perspective that we probably need just a stronger evidence base on what should be real time and what shouldn't. And what the spectrum is between static and real time, so that we could do a better job of determining what information we should be working to collect and how aggressively we should be moving towards getting to real time versus just having continuously refreshed data. But again, hammers and nails, this is kind of where we found ourselves. So I would just make the last point that I think if we're looking at this holistically, one of the biggest questions that we continue to ask is how are we measuring success? So across what Craig said and a couple of the other points, just thinking about how we're able to measure success and what those measures are and how we're able to take this data that we're collecting to be able to do that iterative improvement. Thank you.
Good afternoon. Wow, I came a long way from Texas for that kind of a welcome. Thank you so much. This is what happens when I'm out with the Brooklyn, Bronx, whatever part of New York crowd, right? Is that how this all works? Okay, I see it, I get it. So it's great to be here, and it's great to join my colleagues here. I particularly want to thank Eddie for moderating. Eddie and I were on the Institute of Medicine Crisis Standards of Care Committee together, really looking at surge capacity. As you remember, there was a way to really look at no-notice events as well as slowly evolving events, and very quickly you're in the middle of a surge event. So I am going to come from a couple of different perspectives, and I do want to thank Tom and Art for inviting me here to this great symposium. So I am the health director, for those who don't know, the executive director at Harris County Public Health, which is the county health department in Houston, Texas. And we are a large community, kind of not as big as New York, but large enough, yeah. 4.7 million people, third largest county in the U.S., and we would be, as a state, somewhere between Kentucky and Oregon, somewhere between number 25 or number 26 as a state by population, and we're spread over the size of Rhode Island, which isn't admittedly a great big state, but it is a great state, and so we do like to say that it is a state that we do compare ourselves to. We have over 145 different languages that are spoken in our community. We're home to over 90 different consulates from across the globe. And so when you put that all together, you've got this incredibly large territory. You got a lot of people, but you have this incredibly diverse community, which really requires that we have to be thinking in a very multicultural, multilinguistic way, which is not uncommon for what you all may be thinking about. The challenge that we have in our community is that we have a lot of emergencies. And so going back to Tropical Storm Alice in 2001, when I've met quite a few people. In fact, I was the health officer right before Kim Schoaf. I was like my second week on the job, and Kim Schoaf was doing some sort of exercise in Houston, and she decided to say, is there any local health officer in the room? And I happened to raise my hand. I was the only one. And she put me on the spot about anthrax in the middle of that. I had no idea what I was doing. And she was like, oh, you're going to answer all the medical questions about anthrax and local health officer. I was like, what are you talking about? So thank you, Kim. So glad that she's in the audience. I just want to throw that one back at her. But if you go from Tropical Storm Allison in 2001 to Hurricanes Katrina and Rita, Katrina, which obviously was New Orleans and the Gulf Coast, but we had 27,000 evacuees that were at the Astrodome. Hurricane Rita, when we were evacuating the evacuees, and certainly 4+ million people were on the roadways and landlocked, and essentially we had deaths on the freeways, unfortunately, to a hurricane that never hit us, and then Hurricane Ike that did hit Galveston and Harris County, where people then did not leave because they were worried about what happened during Hurricane Rita, and then 90+% of Houston was without power for several weeks. Now that became a big issue. And then you go through with 2015, 2016, Memorial Day and Tax Day floods, which were really essentially 100-year floods that were supposed to only happen not that often, to be followed by 2017 Hurricane Harvey. In the midst of all that, we've obviously had H1N1, Ebola, Zika, monkeypox, and you go down the list of that. Chemical chemical incidents that happened, including, as you saw just recently, just a few weeks ago, where our team was responding to a large chemical fire, petrochemical fire that was there was a plume across 4.7 million people, and the entire community was concerned about their health issues. It has been a community that has been under an incredible amount of duress over the years by these incredible number of emergencies that we've been hit, both natural disasters, slowly evolving ones, but also no-notice events that have really made it very challenging. And I didn't even mention in 2003, we were the first community to have the BioWatch hit. So that, you know, if you add to the mix of all that. So when we look at emergencies, we really look at this as a narrative, as a history, as something really about what we have learned from previous incidents. How do we recognize what worked, what didn't work, and unfortunately, we don't want to share what didn't work, right? That's always the hard part of research, right? People want to talk about the successes, but we have the challenge that we have to really think about what didn't work and how do we move forward with that. And what didn't work is something that we see as this opportunity for really to build the resilience and the recovery phase. So it's 2019 now, right? We've already had 4 cases of measles in Harris County that I confirmed back in January, February, with over 400 contacts that our EPI group was doing for those 4 individuals that contracted measles. In addition to that, we now have this petrochemical fire that we've been working on. We're about to hit mosquito season just in about a month from now, which, as you know, Zika and other types of diseases like everyday West Nile virus are very much in play in what happens in Houston, Harris County. So when we think about all these different activities, really from our standpoint, I do agree with Megan in saying that public health matters and local public health and local communities absolutely matter. I think that is the critical phase of what we have to remember, is that we have to include in research an incredible amount of understanding of not just the responders, not just the agencies, but that community voice. The community voice is oftentimes left out. And research oftentimes does our best to get the responders and all of our, even if you get to the point of partners and say, what did your staff feel in the midst of an emergency, in the midst of the recovery process, we fail to really recognize what happens in a robust way in the community. So I'll give you an example from Hurricane Harvey. So Hurricane Harvey, as you know, was Harris County, a third of Rhode Island was essentially underwater. And as we were underwater, we had this incredible amount of need to get into the community. So while everybody was looking at the healthcare system, and I'm a physician, practicing physician still at Texas Medical Center, which by the way is also a challenge because it's the largest in not just the county, the state, the country, the world, right? Because it's Texas, it's got to be the biggest in the world, so the biggest in the world. When we had people that were coming into the healthcare system, we were able to count them. We were able to count their needs. We were able to count their health issues. The challenge we have is that when people are disconnected with the system because they're too busy recovering, too busy cleaning up, too busy sweeping whatever or cleaning all the different things that are happening in their communities, how do you count them? How do you get to them? And so what we did is we used Caspers and we did all sorts of things, and we wound up knocking on doors and getting into the community. When we got into the community, we started to recognize that all the things that we were saying in the healthcare system were important, but they weren't the true full picture of what was happening in the community. So we have to get into those communities to be able to knock on those doors, or using social media platforms, electronic platforms, to be able to capture data of what's happening in those communities in and outside, I should say, of that healthcare system or whatever system it is, because oftentimes in the middle of an emergency, as you all know much better than I do, that we have those systems break down. And when they break down, it is very difficult for us to then be able to get into the community and understand what's happening in those communities in a very bi-directional way. We're getting information to our community, and the community is getting that information back to us. So there are a lot of things I wanted to say, and I think it's probably better that I do one thing, which I don't have slides, Eddie, but I did have a video that I wanted to show. See? And what I wanted to do is to really talk about and just show this video and really to capture the essence of what does it mean to be in local response. In a local community, when our federal partners come in, our state partners come in, our regional partners come in, But at the end of the day, we are a part of the community. The community is expecting our local response systems to be there. And by the way, we're still recovering from Hurricane Harvey. So when the federal partners and the state partners have moved away and the media is no longer looking, we're still there with our community. So this video is going to show a little bit about how what we did during that Hurricane Harvey response really underscored how challenging it was for us. But I just want you to think about the fact that this is just one of the 15 to 20 emergencies that we've had over the last decade plus in our community, and so certainly we have a lot to really share. Yeah.
Thanks. You know, it's even though we weren't supposed to have any videos. The key is certainly not from New York. I think it was a terrific way to get us into the mood of thinking about what it's like on the ground. Over the years, as we talk our way through these kinds of events, we always talk about events being local. Every event is local. I mean, to be quite honest with you, in the larger populations, as you point out, Dr. Shaw, when the governments leave, or before the governments get there, whether it be state or local, it is local. And if you think about it in terms of response, how much can even a state agency or a federal agency bring to the table in a place like Texas without the resources that are already there? The 100,000 cops, the 100,000 firefighters, the 200, maybe the 80 to 125,000 medical providers, docs and nurses. There's no way to supplant that, even with the ginormous federal response. Ginormous is a Brooklyn word, but so listen, we have time, so I want you to open up here and ask us some questions. We have some questions that we'll use later if we need them, but to be honest, I'd like to hear from the group. All of you represent different parts of the community in terms of response. So the team here is ready to try to answer those questions and provide feedback to you all. And I think that that's an important thing to hear from you. And so if you really do have a question, we've got some microphones up. Step up and ask us those kinds of questions. To keep us moving forward, I have a couple of things I'd like to sort of jump in on if we have time, but ours are secondary to your questions. So you were the first up, sir. Please identify who you are and ask your question.
I'm Gus Ventura. I'm recently graduated with my PhD from George
Hold on, the
Washington.
mic's not on.
Oh.
It will be
Okay.
shortly, I think.
Yeah, there we go.
Oh, there you go.
Thank you. My name is Gus Ventura. I recently finished my PhD at GW. During my research, I worked with Richmond Ambulance Authority and with one of the local hospitals in Richmond. And when I did my simulation later for my research, one of the feedback comments I had was this sort of lack of confidence in what the algorithms and the black box was putting out as recommendations. And even though they agreed with the recommendations, they wanted to see how it worked. How do we bridge the academic, I guess, proposals with the real-time application?
That's a terrific question. Who wants to take that one?
So David had asked this question before, and I think part of it is setting up a research agenda in advance together. I think that this happened somewhat during Sandy, and that's possibly a model to build off of. But I think if we sit down with the community at large, but public health care providers, EMS, and we develop questions that there's buy-in for and that they need answered, then when you come back having conducted that research, there'll be kind of you'll have this long-standing relationship where they'll have contributed both to the development of the question, to the process by which you ask that question, to participation in the research, and there'll be a lot more buy-in for the results that you're sharing with them.
Okay, thank you very much.
Terrific response. Dr. Shaw?
So, and yeah, not, I keep missing the instructions about the microphone, so I apologize that I'm not getting it correct. But I would add to that, in addition to what Megan is saying in terms of trying to do this up front, you have to be very mindful that emergencies happen very much like I mean, you're sitting at your desk, it's usually about 5 o'clock on a Friday, right? But you're sitting at your desk and boom, it happens. And so now in the middle of it, and as you all know, many of you know Josh Sharfstein with Johns Hopkins University, and he's written a book that he talks about, you know, the first thing you have to recognize, you're in the middle of the emergency. And I think that's the first recognition we have to have. So our recent chemical event was a really interesting example of social media scientists that as we were putting out information on social media about here's what is happening in the middle of this incident, we had, I mean, all over the world, people coming back at our social media postings and saying, I disagree. No, here's more information.
Right.
Here's information that we found. Here's, you know, it's Google Doc, but in an incredibly extreme way.
Okay.
To this degree that I haven't seen the level of real angst that was driving some of those, because we had essentially two events. We had a fire with lots of petrochemical that stuff went in the air. 4.7 million people said, you're monitoring the air, how is it safe when we see a black plume? But then a few days later, when the fire was out, there was a leak of benzene because the foam they used to actually cover the fire had moved, and now there was a shelter in place in the surrounding area. So people then were then saying, therefore you must have not been telling us the truth about what was on the ground prior to this, now because there's benzene. So we had to now manage two different messages, very nuanced messages. As we were doing that, we had all sorts of people that were coming at us that were very much, I hope nobody in this room, but academic partners who were saying, wait a minute, here are the levels that are safe for benzene. Here's the graph, here's this. And it was hard then in the middle of a response for us to be able to adjudicate on social media this real challenge of a debate on science when we're in the middle of response and trying to protect our community. So 2:55 a.m. in the morning, we're now having the first time a benzene leak, and you know the trend is going up, and now there's a decision made to shelter in place. And so people are saying, well, wait a minute, but those levels weren't high enough to warrant a shelter in place. Why did you shelter in place? And we're saying it's 3 o'clock in the morning and there are schools and people going to work. What are you supposed to do when it's 3 o'clock in the morning and now you're about to make a call? So there's a real big issue on research and science. So what we did is we pulled in University of Texas School of Public Health, grabbed our pre-existing MOU, grabbed the researchers and parked them with us. Right? And they were right there. So as we were making governmental decisions, we had an academic partner who was also saying, you know what? That makes sound science sense. And now it became a more global way of being able to respond back. And then we, after the fact, brought the CDC and ASTDR to come down, ATSDR, sorry, to come down and to really do a follow-up consensus statement on benzene testing in our community. So it's just an example of how social media has changed everything.
Yeah.
Everything when it comes to getting messages out. And we have to be prepared for those social media naysayers that can very quickly get you to another situation very quickly, even in the middle of you doing the response activity.
I just want to take my prerogative and just get a little bit more granular here with your question. Your issue was a concern by the response community to allow you in. Is that what you would describe?
Once we developed the product based on the field research, and we actually had them come in and use the product, and even though they agreed with the recommendations being made by the system, there was still this reservation that they were being told by a black box. It was a term they
Right.
used a lot.
And did you, so just because I know I'm going to try to keep us on time, and I'm probably taking us in a little bit of a different path, but that's so important. Let me ask the group, and certainly all of you can answer this question, and you too. How do you build that trust ahead of time? Practically tell us how you think you build that trust with the response community ahead of your study, during your study, and after your study to make it real.
So I think the thing I didn't hear about in that was during. So the outputs they agreed with, the inputs, how much input did they have in what you put into the simulation?
It was limited to a group of people down in the
Right.
Richmond area, and there were people in the simulation that weren't from that area. So,
Right.
but the folks in Richmond, I guess, had a stronger comfort level, and I guess it's reinforcing what you're saying about if they're involved at the beginning, they're going to be much more comfortable with the results, whereas everybody else agreed, but they weren't as comfortable.
So I'm happy to talk to you about this for as long as you want offline even.
Absolutely.
But I think the challenge that we see is that while the response community, and we're kind of saying response community, may have input, you have to think about what we typically refer to them as nodes, but like what those nodes of influence and information should be, and how to get not just consensus from them on how you ask the question, but having that iterative conversation with them. I think it's more of a traditional public health approach of thinking about this kind of community-based research model, right? But how do you continue to make sure that as you are putting the inputs in, that you're saying not just to, kind of a small self-selected sample of people who will talk to you and not yell, but really a representative group of
Right.
folks that are saying maybe you should think about this or that or the other. And I think that may be part of where that breakdown lies.
Okay, thank you.
And you know what, terrific answers to that. I'll add one thing from my side, and that is, if you're going to convince the response community that you're going to be on the scene, their concern is they're going to talk to social media, and you will be, no pun intended, the leak that says we failed to manage these patients correctly. And that's why you need exactly what the group is saying. Nodes are the right people. I'm from Brooklyn, so that's how I interpret it. The understanding around social media and making sure you have an understanding, because that's what they're looking at.
Right.
Their funding, their supplies, their public reputation depends on, sat at a scene of an incident when something goes bad, and it always does, anybody who's done it, the last thing they want is an unknown entity documenting that and publishing it. So you need to have that trust ahead of time. Terrific question.
Thank you, sir.
Terrific question. Thank you. Ma'am.
Hi, I'm Tricia Walkendorf with the Disaster Research Center at the University of Delaware. And I'd like to ask you to push a little bit further in the area of identifying questions that are useful for practitioners. I think that many of us as researchers are driven into the field because we do want our work to make a difference on the ground, and we are reaching out in ways that go outside the traditional journals. But it's difficult sometimes to know what questions you actually have that goes beyond just a one-on-one conversation. I think some of those times you might have questions as a community as opposed to an individual that we actually know the answers to, and there may be decades of research and we can just say, here it is. At other times, there may be questions that have us step back and go, we've been looking at it this way. This is actually the way that we could be looking at it and have that basic science actually have an applied impact. So as practitioners, how do you pull those questions through your community in a way that's not burdensome, but also gets that information to us so we can deliver. Thank you.
Who wants to take that one?
What resilience investments in infrastructure actually improve health outcomes after a crisis? I don't know. And I think there's conjecture, but there's no evidence base. And I actually, as you were asking the question, one of the struggles I realized to the previous point was that there's a lot that we know based off of kind of historical knowledge, previous responses, anecdote, that may not be in evidence base. So even if we think we have the answer, it's possible that we still need evidence base to guide how we do both the planning and the execution.
So that's such a difficult question. Anyone else want to take more? I've, if anybody wants to talk specific process.
So I guess we got a question in advance about what health data would be most valuable. And I put this question in the same category because I think that there are thousands of research questions that you could ask, right? So I think it really depends. Like I think back to when I worked at the health department and H1N1 took place at the time, right? And so we had a research question around, was it more cost effective to run points of dispensing or was it better to do school-based vaccination, right? So we actually did that research ourselves. So I think that there are lots of operational questions that health departments will have, and that's why I would encourage, there's like a bad echo. That's why I would encourage you to have an established relationship with your local community that you can lay out what those questions are, because there are some that are going to exist that are perhaps about logistics or about things that cover multiple emergencies, and then there are some that they're not going to know until the time of the emergency, like what's the efficacy of the H1N1 vaccine. And so I don't know that I can say that there's like a list of like, here are the questions we must answer.
So, one of the things, Lori, want to add anything to that? Go ahead.
So I agree with both what my colleagues have said. I think it's really important to just recognize that, one, that there is governance structure and response structures that are very different across every state, every locality. And that is both a burden, it's also an opportunity, right? I mean, there are a couple ways of looking at it, but academicians or our research partners who can help us with lumping or clumping like communities who have responded or have had emergencies, but let's say Florida has responded to hurricanes, which it has, but it's a centralized government. Texas has responded to hurricanes, but it's a decentralized government. Well, how do we find those kinds of states and communities that are responding to emergencies, but they have different governance structures, different uniqueness to their response capability, and then lumping and clumping those together so we can now start to share? Because it doesn't help me, as much as I was talking about Rhode Island, it doesn't help me to get as much about Rhode Island because the emergencies that are happening are very different than what's happening in Houston or in Texas. So I've got to find ways to do that. And so we try to do it from our local public health communities of practice and sharing. But to have academic partners help us with that question really helps our teams, because now we can start to really ask very different questions, very granular questions that come to what is it that's going to help my response and my response community to do a better job, which is not the global everything around the country. It's really tied to specifically what's happening in communities that are very similar. That's a really important point where our research partners can help us. The other piece that I think is really important is that data sharing in the midst of an emergency is very difficult. It's certainly difficult after the fact, but this nuanced understanding that you are in the middle of an emergency, because we get a lot of reach outs by our academic partners in the middle of the emergency, not to help us necessarily with the response, but to say, wow, wouldn't it be great if that's a great research question? We would love to take this for you. And we're too busy in the response to even put bandwidth over here. So what we're doing is we're creating, and we've created an Office of Science, Surveillance, and Technology. That science area are now people that we in the department are not tied to the response, as in their responsibilities are to respond, but their responsibilities are to become liaisons back over to the academic world. But we have to make sure that that response and research, that it comes together. It's not an either or, it is an and.
So,
We're
I just
going
add-
to just move on, but I'll go ahead.
So
Quickly.
the reason that I talked about capacity is what Umair's getting to here, that there isn't the capacity in the department to necessarily do this research. But rather than figuring out the questions we ask now, I think we need to figure out the mechanisms by which we collaborate between academia and practitioners. So for instance, are you embedded within the incident command system? Are you physically going to be on scene? If you're collecting data, how do we differentiate to the public that you're a researcher versus me as the practitioner? So I think it's more important to figure out those logistics of how we'll do the research than the specific research question we might have and what that dynamic is.
Yeah, so just calling us doesn't help. But as Megan, if you're actually there on ground, that's a very different mechanism of getting that information together.
And terrific answers to the questions. I'll add one or two quick things and then go on to our next person. From a practical perspective, when you publish, I think one of our speakers spoke about this, it needs to go to the community that you're trying to get their attention. If you publish in a major medical journal, which is what a lot of you do, or in a major journal around public health, that's not necessarily going to get to the ED nurse or to the paramedic in the field or the fire chief. So that would be my first suggestion. Where do you package it and how do you distribute it? And second, I would say anything we do should get into education somehow, so that it becomes a standard process that's looked upon, just like they do protocol for management of cases in EDs, as they do protocol for management of incident management. All the major response authorities have standard guidelines. They tend to focus on real hands-on operations, but if they had the concepts that you find that were proven and tested and studied, they would learn those concepts and use them. But if one place doesn't know about it and another place does know about it, then it doesn't become a standard that crosses across the nation. And we have seen that, as Umar will tell you, in just the field protocols for the management of triage around patients. It's changed 10 times in the last 12 years, okay? So, because some worked and some didn't work, okay? So that's a great question. Baby steps, right? You can't eat the elephant at the same time, one bite at a time, right? However, you should exchange your business cards with the elephant before you actually see it. Sorry.
Only if it's local.
Only if it's a local elephant.
Regine Webster, Center for Disaster Philanthropy. How do the three of you hope that your work will either be influenced by or influence the local, state, or national VOAD system?
So we are a part of the VOAD, and I'm going to take state and local first. I view the national VOAD as more kind of an aggregator of leading practices. So I think the question of the role of volunteer organizations and the opportunity to fill the gaps that remain by volunteer organizations is pretty massive. What we hope to do is to both use the information that we're providing and the logistical support that we provide during events to help inform that. We are often a logistical and coordination gap filler for a lot of our VOAD partners during a response. So that is one kind of immediate tangible thing. I think in the long term, though, what we have always hoped to do is to help our VOAD partners and our other sector partners understand the role of partnership and collaborative engagement. One of the things I've been harping on this year is integrated coordination. So we talk a lot about how we coordinate, but how we integrate is just as important. And so that's something that, for me, I think the VOADs can really lead on, because as individual organizations, they have to figure out how to integrate. If the true goal is to help and assist, we've got to integrate better, and then we think about how to integrate with the overall system.
Great. Hope that helps. Ma'am?
I'm Kim Sho from the University of Utah Office of Humanitarian Leadership and Emergency Health, otherwise known as the person that made Umair cry on his second week of the job.
Oh, do you have a video of that? I just would like to see that, Tom and I.
I've actually made sheriffs.
By the way, just for the record, that ages you. Just
Yeah, it does. It does. I've made sheriffs cry. I've made lots of people cry in exercises, so I know how to break the system. One of the things, talking about aging me, 20 years ago, as a young researcher, a team of young female researchers got together and started talking about interdisciplinary work and how we can work across the fields of engineering and public health and medicine. And how do we get data from the data generators, you, the locals, through that little pipeline up to those the researchers that can use that. And one of the things that we talked about was trying to identify common parameters and common data variables that are collected on a routine basis by public health, by medicine, by EMS, by all of the different pillars that are involved in this. We never got very far because we never got additional funding to be able to do that. What are the things that you would like to see in that sort of thing? We do have funders in the room that might be interested in looking at that, and how would we move that forward so that we're not there on the scene interfering with your response, but we can aid your response as our students, as surge capacity, and then work together afterwards to analyze the data that you are naturally going to be collecting.
Great question.
So one quick response, and thank you, Kim, for that, is to really say that it would help for us to have a repository of who you are. We have repository of, our locals, Rice University, Baylor, University of Texas, A&M, UTMB. I mean, we have all that. We even have some regional partners, like Tulane University comes to mind, others. And we do stuff even with London School of, Tropical Medicine Hygiene in the UK. So it's not that we don't have partners, but honestly, these are partnerships that have been built on relationships and understanding. And so what I would really recommend is, or at least explore, is this opportunity of really giving us a landscape of who you all are and what you all are working on. What are the questions that you're interested or have the capabilities of being able to help answer? Because that oftentimes is a one-way street, that it's like, we get the call in the middle of the emergency, we'd like to help you with this, but it would be great if we actually knew who had interest in community engagement, others who have interest in data reconciliation, others who have interest in the technology piece, and to really put that out there somewhere where remember I mentioned this science area, could now have that as being a way to be able to touch on something. So creating a system that allows for public health practitioners or response practitioners to be able to reach out very easily in the midst of an emergency and say, we've got this issue, we've got a question we've got to answer, but we don't know who to go to. Rather than Kim calls me up and says, hey, Omer, hey, remember 20 years ago when I made you cry, that kind of thing? It really becomes a systematic effort. And I have not seen that, really, that helps us in the field.
That's what the Alliance will do.
Well, there you
Exactly.
go. And that I think is going to be absolutely incredible for us.
Terrific.
I want to make one quick point.
Go ahead.
So we've been talking a lot about the capacity or the desire to not overwhelm our public health partners during a response. There's a whole other part of a local response that we haven't thought about, which is the private sector. So if you're thinking about, a lot of these private sector entities have EOCs, are collecting data, would honestly be willing to determine what your EEIs are for research and try to either integrate or adjust some of their outputs to be able to provide some of that if partnerships were in place. But as you were talking, one of the things that I realized is we work with a lot of the distributors, whether they be the multinationals or the locals, and almost every single one of them has an academic partnership. But they are partnering with the Centers for Supply Chain Integrity or Supply Chain Resilience, whatever that's called. And so it occurs to me that this is one of those left-hand, right-hand things where maybe there's a partnership that could exist on the academic side, where the Center for whatever, supply chain, whatever it is going to partner with the folks that are in this room, because it's possible that they're collecting information or already have agreements in place to get that information to you that could be useful for disaster analysis.
That is so true. To just add a little bit of that from my old job, I was a director of global crisis management for the Walt Disney Company. And supply chain for them was primarily something that they never wanted disrupted. So when they're in our crisis planning for them, they had backup to backup to backup, with the presumption that the company that they were dealing with would fail. And lots of private sector companies have that. So it's about how to, like, as you're pointing out, how to connect with them to make sure that you have that visibility. It was magical. Yeah,
Magical.
it was magical.
You don't hear magical much.
Well,
Magical
Aubrey,
thinking.
one-
You put me
before
up
you, one other thing I want to put on the table is economics. So, Clark County in Washington came out with the figure that with measles, they spent $1 million on their response. That is I know the director, but that's woefully an undercount of what that costs. We have 400 contacts for 4 cases. We do not have the health economists on board. That is an area of an incredible need at the local level. What happens is we give all these federal, national figures of stuff that doesn't help our local elected officials and responders and even decision makers to say, oh yeah, CDC says nationally X number of dollars, but it's really this much that it means for a community like yours. That's what we're also I think that's also very important.
All right, so I'm getting the hook, so I'm only allowed to do, these, Tom's up here giving me the hook. I can only take 2 more questions, and by the people that got up first, I think on this side, Dwayne, and as much as I love you, and you know I do love you, and
That's
we're gonna go to this side, so please help us stay on time so I don't get beaten up as the moderator.
love
Yeah.
all around, Ed.
No, you're up. You're
Aubrey
next.
Miller, NIH, and Nicole, if she's coming up. This is a great conversation. I wanted to just come back to this place that you took it, Umar, and in terms of local capacity and the interface with getting good science and information to support you, and what's that process look like, right? So we've dealt with some big disasters, and one model was the National Academies stood up these quick workshops,
Yep.
right? So there was one for the Gulf oil spill, which we did in New Orleans. We had one for Ebola. We did one for Zika. And that's kind of an interesting forum that didn't have the community voice, which was part of the problem of it, but at least it brought together a large interdisciplinary group to talk about what do we need to understand with respect, what are our data gaps, what does our backside look like. Okay, this happens all the time, as you know. I mean, you have the benzene situation, and somebody could easily said, we don't understand benzene in children, or whatever it was, and we probably didn't have data in that space, and you could have gone, yeah, it's a gap. So it's kind of, what do we know? And the next question is, what are we going to do about what we don't know? And what is the forum for that? And I like that you created something now in your house to create a science interface with academia. I'd be interested more, also we'll continue this conversation, but what are some other ways that we can construct the right platform for that conversation in terms of what we don't know and bringing a transdisciplinary perspective to that conversation rapidly at the community level?
Thanks for throwing my name at the beginning of that question, so they're all looking at me. I think what you mentioned with the National Academies, obviously a proud member of the Health Science Policy Board and with NASEM. And what I would say is that there is as Megan had mentioned, this sort of ongoing, how do we build a platform or an infrastructure? But I think we have to remember is that these emergencies are so chaotic and unpredictable that while we can predict that, I think that the prediction that you will have an outbreak of vaccine preventable diseases in X communities in America, that can be modeled and predicted. You can do the same thing with hurricanes and natural. There are going to be propensity for communities, but I think it's how do you then get, while people are still in the response and recovery phase, to get those voices back over to the research side or the folks that are trying to say. So the way NASEM has done some of those where it's in DC, but then they've also these regional workshops on the ground, that absolutely has been very helpful. So I think trying to not get us to leave the community where we're responding, but to bring those folks into our community at the right time to say, hey, here's the conversation, let's put that, that information together, I think is very helpful.
Right.
And what does the management of that look like from your perspective or for others? I mean, how would that take place?
I
Who would
think it
run
has to
that?
be joint. It has to be joint management because it has to include the folks who are also in the midst of time constraints, but they're the ones that have to be there. But it also obviously includes what those needs are, the folks that are interested in the question. So I think putting both together, because if it's just these individuals putting this together, it's not going to work because we're not going to have buy-in. If it's just these people, we don't have time. So if we don't have time, we're not going to put it together. We're not going to put a workshop together. I'm not going to put a workshop together right after we've had a chemical event. Like, oh, let's do a workshop now. What? We had a town hall last night. I mean, the people are still in our community concerned. So we're not going to do these workshops. It's very hard for us to be able to do that. So you have to do it in a really integrated manner. And working with groups like the National Academies or NACCHO or ASTHO or others, there are so many folks that we can really work with that would help put those together. But we need the funding.
Appreciate the question. Dwayne, lightning round.
So just a quick comment, Dwayne Kaniva from Department of Homeland Security. I'm reminded of a book by Jeffrey West called Scale, where he looks at the nonlinearity of things that scale, and he spends a lot of time talking about biological systems. And I wonder if that's the problem we face, where we are off the scale for the way we try to capture detail, the way we've reached such degrees of specialization, subspecialization, and you can try to capture that, publish it in peer-reviewed journals, and you miss the interdependencies and the interactions across, even within the health sector, but across those critical sectors. Does our current system allow us to capture that level of detail, or do we need to look at other ways of capturing this data? As you talked about, a standard process. Do we have adequate standards processes, standards development processes, where we can take a bunch of smart people like this and have some sort of outcome that is meaningful, that contributes to a standard, a national standard that moves things forward?
It's a great point. I'm not sure if we've got an answer to that, but does anybody have? Okay, so listen, we're all here. We're gonna, as you can see, I've got the bodyguard standing right over my left shoulder here. But these were terrific questions. It's always good to have a discussion and then have the people ask the questions rather than us making up some that were good ones, by the way, of which we were able to touch our way towards this. But special thanks to the panel of experts. They were terrific. I think we could all agree. And thank you for participating.
Great. Thanks, Ed. Okay, we're going to push on. The good news is that the second to last questioner ate into his own time, so I don't feel quite so guilty that we're running slow. So I'm going to invite Aubrey Miller, Dr. Miller, up to lead the panel, and we're going to turn towards the federal funding issue to talk about where the money comes from and where it goes, et cetera. So I'll let you introduce everybody.
Check 1, 2.
Okay, did everybody have a fun break? You could stand up and stretch too. I think that's good. It's good health. We should just practice. Everybody stretch. We're going to talk a little bit about that really fun issue that I unabashedly kind of set up a little bit of the conversation, talking about funding, which is, this is a shared experience that we're all going to agonize through some of this. Though, by bringing up that issue, partly in my last question from the audience, was thinking about, we had these workshops that the national academies essentially led, right? And they were fairly rapid. They were down in, the Gulf Oil Spill happened in April. They were down in June holding a workshop in New Orleans. I remember with Hurricane Sandy, we did one in New York pretty close after that event. And similarly with the Ebola and the Zika. And the situation was partly this, is they had these workshops and they outlined quickly a bunch of research issues and needs. And then all of a sudden, Congress allocated some money. Though in the Gulf oil spill, that came from NIH. But with that said, money did kind of come and follow. So if we wait a year after to have this conversation about what are the research needs and gaps, that money is not happening till maybe a year later at best. So this has been an ongoing struggle about thinking about how do we fund. We have our partners up here from different agencies. We'll talk a little bit about their strategies for doing it, but we have to be really creative in this space because we don't have FEMA writing a check, right? So not like in a response situation, FEMA gets out their checkbook and says, okay, clean this up, get some information on this or do that. When it comes to this kind of data collection, which is incredibly important, we know, there's nobody writing the check, so we try to hobble it together. Maybe with that said, why don't we get into our speakers a little bit so we can leave time for a little bit of brainstorming and some more questions in this space. One thing cool that I'll mention before Robin comes up is we did, and Umar, unbeknownst to him in many respects, this was going on in Harvey, is that we were actually on phone calls together with NSF and with Department of Homeland Security and other agencies, sitting there trying to figure out how to fund more collaboratively and collectively and thinking through what were the research questions and how do we allow our research parties and their enterprises come together in a creative way to be supportive. And that was the first time I've ever seen that happen, and this wasn't, being hoisted at a federal level. It was just us doing it. And it was a cool interaction, and I'd like to, explore that further in the days and months to come. With that, I'm going to introduce Robin Dillon-Merrill, our program director from the Human Disasters and Built Environment of our National Science Foundation. Thank you.
So I'm just going to make a couple quick points because I don't actually know what any of you want to know about the National Science Foundation. So I'm going to make a couple quick points and then turn it over and hopefully allow more time for questions. One thing that I have to say is that I'm only one person at the National Science Foundation. There's 7 directorates. Within the directorates, there are multiple divisions. Within the divisions, there are multiple programs. So I can speak for what my program does. I can sort of tell you what I know some other folks sort of do, but in no way can I speak for the National Science Foundation on what we fund and what we don't fund. I will say that most important to us as the National Science Foundation is intellectual merit and broader impacts. That is what our proposals are funded based on: new intellectual merit, new knowledge, transformative knowledge, and broader impacts. How much they're weighted depends on various different programs, program directors, divisions, and such. In my program, Human Disasters and the Built Environment, they're pretty equally weighted. And by equally weighted, I mean that you have to have really, really good intellectual merit. You have to be convincing me you're going to do new knowledge. But I've got a lot of people that are going to do that. I've got more people who want to do things with new knowledge than I can fund. And so the ones that really stand out are the ones that then have this new knowledge with awesome broader impacts. And that's really what you folks are most in. Seems to be most interested in is having a difference. How does it get out to the community? Would we fund something that is 100% broader impacts with no really innovative intellectual merit? No. And so we're not going to fund the development of some kind of product, or we're not going to fund other things that just really are not creating new theoretical knowledge. And there's a lot of mission agencies here and on the panel, and we want to let them do that. We want the National Science Foundation to still just be where the theoretical knowledge really comes from. I'm humans, disasters, and the built environment. That means that it has to have people in the problem. It has to have disasters in the problem. But my program is in engineering. And so I will fund sociologists, I fund urban planners, but it does mean that it has to be relevant and interesting to the engineering community, and that's what the built environment means. So with health, I'm not going to fund stress or trauma unless you are somehow telling it in the way that it's relevant to engineers. So what are we going to do? I get that the disaster causes stress and trauma, but what do you want your engineers to do differently? Like, how can you frame it in terms of the system? And so, yes, if it's really just about measuring trauma in various different categories of folks, that's not really going to help. But if it's about the numerous hospitals that were burned or taken out of commission in the wildfire, and what were the mitigation and the preparation, and what do we need to do differently, and what do we need our built environment systems to do to protect those hospitals better, then absolutely, that's what we care about in my program. There are lots of different programs at NSF too, but in general, we don't just do pure health because we have other agencies that do that. It also was mentioned we do fund rapids. NSF touts and loves their rapids. Program officers tend to, I don't want to say despise, that's too strong a word, but find them to be more challenging. In particular, I'm a rotator. If you see my bio, most of the time I'm a professor at Georgetown. But I showed up as my rotating position in September of 2017, right as the U.S. was getting slammed by multiple hurricanes, one after another. And so I'd show up and I'd have 30 emails in my inbox that said, hey, can I have money to go do something for this hurricane? And meanwhile, I haven't even found the cafeteria yet. And so what NSF does do is we do have this mechanism that we can make grants rapidly, but they do still have to be fundamental new theoretical knowledge. Like if you call me up and say, hey, there's a really bad petrochemical spill, I think we should go do some sampling. I need to go get some data. My question's gonna be why? Like why, like I'm not just because something happened and somebody thinks they should get data, you have to convince me where the gap is in the literature and what this data is going to inform. And then if I'm actually going to fund it, and there are other programs that would be more inclined to fund sampling from petrochemical spills than humans, disasters, in the built environment, I also need a human aspect to it too. What is it doing to this population? How are the people being influenced? So there is a great rapid mechanism. It does exist. NSF touts it as one of our great success stories, but you need to know your program officers. You need to know what kind of criteria and what kind of constraints they put on it, and absolutely. And additionally, though, programs also have what we call unsolicited proposals, and what Bob O'Connor, which I know a few people in from academia in here have mentioned his name as somebody who's funded. He manages the Decision, Risk, and Management Science program, which is in the Social, Behavioral, and Economics division. One of the things that he is touting in this disaster community